Everyone, welcome to today's Provide First Aid in an Isolated or Remote Location. My name is Abby and I'm going to be your trainer for today. Hopefully before you jumped on that you completed your pre-course, and if you had any issues you contacted the office so that could be rectified. Just a little bit about myself. Prior to working for Rural Response, I was an Army medic. I spent a period of that time in Darwin and Brisbane working remotely by myself, but within a resuscitation team environment. In Brisbane, I was fortunate enough to spend time with the critical care paramedics quite regularly, and also in a variety of their hospitals, in emergency departments, operating theatres, but also burns wards. I then moved to Adelaide to be closer to friends and family. I do occasionally still work as an Army medic within the reserve space and in hospitals here. Majority of my work is with Rural Response, teaching their CPR, their first aid, their remote courses like this, and also their dynamic environment courses. Just something that we want to give you is empowering you with those vital skills to navigate critical situations, because critical situations can be anywhere. It could be in your home, it could be whilst you're walking your dog, at work, camping on the weekends, overseas. You just never know when you need to use these skills. So we just want to give you those skills that you could use if you are ever exposed to that type of environment. Our patient interview, and the two ways we can start to get a bit more information are using the SAMPLE acronym and also the Dolores acronym for pain. So for SAMPLE, what you're checking for is their signs and symptoms, any allergies that they might have, the medications they may be taking that might be quite relevant to things such as blood thinners, any past medical history that could be relevant, the last time they ate or drunk, maybe if they're going into surgery, it could be something to consider, and also the events leading up. So what were they doing prior? Then we can move on to their pain acronym, so Dolores, so get them to describe the pain, when it started, the location of the pain, any other pain issues that they might be considering. Maybe they've got one really painful part of their body and the other's not too bad, but making them consider any other issues or any other issues with the one they're describing. What relieves it? So what relieves it, maybe when they lift it up or support it, it makes it better. And the severity, so 1 to 10, mild, moderate, or severe. Or there's this Wong-Baker scale. So you can see between the 0 and 10, what the phases might mean. And this can be really, really useful for children who don't have an understanding of the pain scale yet. So have a look at their face. What are they showing us? Because pain is a really subjective thing. The amount of times I've walked in to a hospital room and you ask someone, what is your pain? 0 being nothing, 10 being the worst you've ever experienced in your life. And they're telling me 10 out of 10, 10 out of 10, but they were just asleep prior to me walking in. So maybe to them it was a 10 out of 10, but to some people, if you're in a 10 out of 10 pain, you're probably not going to be asleep prior. So after we've checked that, we can then move on to their vital signs. And vital signs can have a lot of numbers and it can get very complicated. So this is something that you might have written down on a card with you, that when you're doing it, you can check it. So we're going to check their conscious state. So again, AVPU, alert, verbal, pain, unresponsive. I told you we're going to talk about it a million times today. Are they able to recall their name, their location, and the month where they're in? Let's ask this person relevant questions that they will know the answer to and that we know the answer to. There's no point asking them when their birthday is and we don't know that answer, because they could tell us anything and it could be wrong, it could be right, who knows. We're going to check their skin color. So what is the color of it? what does it look like? What does it feel like? Are they pale? Are they sweaty? Is it really, really dry? Is it red? This is what we're assessing right now when it comes to their skin. Their respiratory rates. So these numbers change constantly depending on the age of the child, but when we become adults, it sort of evens out quite regularly. All right, so we're looking at the rate, the rhythm, the depth, and is it equal? So if I'm going to talk about adults or adolescents, 12 to 20 breaths in a minute is roughly normal. Where if we're looking at a newborn's respiratory rate, a normal respiratory rate for a newborn is actually 30 to 60 breaths in a minute, which is really, really fast for an adult if we ever saw it. So just understand respiratory rates for the younger generation is quite different to what someone would have as an adolescent or an adult. We'll then move on to their temperature. So this is something we might also be observing when we're checking their skin, but we can use a thermometer right now and check is their temperature normal. And trust me, with COVID, everyone knows how to use a thermometer now. You've got the ones that go in your ear, so your tympanic. You've got your infrared ones that you hold to your forehead. You might find some old school ones that go under the armpit, in the mouth. Just obviously be mindful about what's going where. But a normal temperature is between 35.5 and 37.5. Just something to sort of be aware of. That is sort of a normal temperature, but when we start to check a core body temperature, so their internal body temperature can be actually more than what say a tympanic is showing us or an infrared. So just something to always keep in the back of your mind, especially with someone who's suffering a heat related or a hypothermia type case. We're then going to move on to their pulse, so their heart rates. There's two really common ways that people know, which is your radial and your carotid. So your radial being your wrist. To find that, you just follow your thumb down to your wrist and you put I put 3 fingers, you can put 2 fingers, and just softly do it. Don't try and push very hard or else you might block it, and you should start to feel the pulse. Don't ever use your thumb because your thumb actually has its own pulse and it can make it sort of off. To check your carotid, you're just going to feel around the neck, and you should start to feel a similar type of movement that you did feeling someone's radial. I like to say, though, it's really hard in an emergency situation to feel a pulse, especially if you're not confident in taking one. So it's always really good to always practice taking it on really healthy people who might not be as well. But the more you practice, the better off you will get taking a pulse. There's other ways to take a pulse, such as your brachial. So that's really good on infants around the sort of underarm area. You've got your underarm shoulder area. You've got your dorsal, so the top of the foot, and you've got your pedal, which is inner foot. Trust me, I've tried to millions of times do this, and it does take a bit of finesse to find a dorsal or a pedal pulse. And what you'll find is most health professionals, once they find one, they're going to sort of do an X with a pen, because once you find it once, you might lose it the next time. So it's always good to mark where you found it for the next person. And checking a pulse on the foot is really good for if someone's got any leg injuries, because if you can't feel it, they might have something blocking that circulation. Then we'll move on to the oxygen saturation, so their SpO2 levels. You might have seen this and you might have had it done before, where they put that sort of little machine over your finger, and it uses that infrared to sort of read your oxygen saturations, but it also checks your heart rate too at the same time. So it sort of does 2 things at the same to help when you're checking vital signs. And as you can see, a normal SpO2 is above 94%. Things that might impact your oxygen saturation levels is when people wear nail polish, or maybe they've got really bad circulation to their fingers. So maybe it's really cold, or maybe they've got a medical condition hindering that. So just a lot of things to consider. Then we're going to move on to our blood glucose levels, so the BGL. If they've got low blood glucose levels, that's less than 4, because normal limits are about 4 to 8. When you're getting on the high, you're getting above 10, and then anything above 15 can be quite dangerous regarding blood glucose levels. And lastly, Perla. So our pupils, are the pupils equal? Are our pupils equal? Are they reacting to that light? And another one that you might sort of hear about when it comes to Pearl is Perla, which is accommodating. So when you check one, does the other one do it at the same time? Because they should always accommodate appropriately. So that's our vital signs. Like I said, always great to practice. Really good to have like little cards where you can refer back to things like respiratory rate when it's someone that might be under 18 that might maybe they're a toddler and you need to recheck what their respiratory rate might be because you just can't remember off the top of your head. Next, what we're going to do is move over to our clinical handover. This is really, really important because maybe you just might have forgotten what you did. And if you write it down, you can always read off of it. Or if it's too loud, you can always hand them the piece of paper. So really good sort of way to communicate what's going on to someone. So identification. So such as 25-year-old male. We're not telling any other information. Maybe we know their name. Maybe we can go, a bit more in depth of their identification. But in reality, we're stopping there for the I. Then we go into the M, so the mechanism of injury. So maybe it was a pedestrian hit by a car going less than 30 k's. I have not gone into any more detail about what's going on other than what has caused the injury. So it could be a gunshot wound. It could be a shark attack. It could be a stabbing. All right, we're just keeping it to what was the mechanism of injury. Then we go into the second I, so the injury sustained. So maybe they have a head laceration and a right arm fracture. So we're just telling them what injuries they have, not what we've done to them, not what we've done to assess it, just what we can see. Then we go into our signs and symptoms. This is where we're getting a bit more in depth of what we're doing. But sometimes we might just have to keep it very simple. So airway, is it clear? Breathing, maybe, yes, they're breathing. What's their respiratory rate now? 22. Maybe they have unequal rise and fall of the chest. So we're now going into a bit more detail about their signs and symptoms. Bleeding. They've got a bleed on their head from that laceration. How much blood are you assuming is coming out of that? Remember, we always overestimate blood loss. So less than 200 mils is great. Greater than 500 mils, you don't need to get that exact number. Just sort of have that sort of rough estimate of what it's less than, what it's more than. Maybe they have a deformed arm. Maybe they're complaining of 10 out of 10 pain or 7 out of 10 pain. So we're just giving those signs and symptoms that we can see, the vital signs, and also what our patient's subjectively telling us. Then we're going to move on to treatment. So maybe our treatment was we checked for danger, we checked their response, we sent for help, we checked the catastrophic bleed, we cleared their airway and breathing. Maybe we put pressure on their head. Maybe we splintered their arm. And we just continued their reassessment whilst we were filling out this documentation. So this is where we're putting all the information down of what we have done to help them. So this is our clinical handover and how we are going to hand over a patient to someone else. One thing that's really important for IMIS is it is for an individual person only. So if we have 5 patients, we need to do 5 individual IMIS for each patient. All right, we can't just do one for all 5. So that's our clinical handover. What we're going to go over to next is our triaging. All right, the only interventions we should complete when we triage someone is we need to stop life-threatening hemorrhage, so a catastrophic bleed, and we can open their airway. How can we open someone's airway? Maybe we do that head tilt, or we put them in the recovery position. You can follow the bouncing bowl. This is probably best done by non-clinicians because you don't overcomplicate it. So if there is no breathing present even after you open their airway, the person is actually classified as dead. All right. That's because this is used for a mass casualty situation where you have multiple people that you're trying to help, and maybe you don't have the resources or the personnel to help everyone. So you need to prioritize who gets the help first, who maybe could wait a little bit, and who isn't as sort of critical as what could be. One thing that I was always taught is those delayed, the people who can walk, might be people that you can get to help you with patients to treat. So maybe those urgent, they might be able to treat them, they might be able to sit with them and communicate with them. So you can always use people around. But the unfortunate thing is, we should never do CPR in a mass casualty situation, because we will be wasting resources that we can put to maybe those immediate patients that we need to help. All right. So that is triage. When we are also thinking about a sort of a situation and where it is, we need to consider the evacuation. So details required for evacuation is their exact location. With that, we want to consider the access and egress. You can see in my photo that I drew that if there's a car accident on the road, you need to now consider how the emergency services are going to evacuate those patients. There's no point rushing in vehicles and loading up that ambulance at the very sort of start, that closest ambulance to the situation, and then they can't get out and they're trapped because you've just pushed in a lot of vehicles. So we need to start to think about how they're going to access the location, but how they're going to get out quickly. So for the one that's on the screen, it might be them, you have like a little U-turn that where they can escape from, or maybe we can just keep going straight and take the way to where we need to go from that. So just things to always keep in your mind. So the exact location, sending a person to wait for emergency services is also something we need to be mindful of. Trust me, there's a course I teach and it's like in a dungeon, and people who spend their whole life at that workplace don't even know it exists. So always making sure that you send someone to alert emergency services when they've arrived and you're not wasting time. Maybe the available resources in the area or the transport options. So not all hospitals are the same. Not all hospitals in each country are going to be the same either. They don't all have the same sort of capability. So things like a cath lab for heart attacks and maybe strokes, burn centers, a trauma center, they're all different. So we really, really need to be mindful about our available resources and the transport options. Because in some countries also, you might not be getting a qualified paramedic like you would here in Australia. You might just be getting someone who's just driving that vehicle. So we need to make sure we're aware of their training too. We've got moving a patient. So how are we going to move them? Can we move them on a soft stretcher, a rigid stretcher? Do we need them to be brought to us to move them because maybe they've got a spinal issue? So we might need a spinal board. So this is all things that you are considering with evacuation, and also informing the emergency services of that also. Also, who made a tent? So you might get police to help rescue. Ambulances, so they're special operation paramedics that you can get in most states. The SES, fire and rescue, helicopters. You might have fixed wings to rural locations with an airstrip, especially if it's past where the helicopter can go because they're only limited to a certain distance. You might have the military help. So you may have different types of rescuers attending. So being maybe considerate about that. And lastly, aeromedical. So with this, 000 operators in Australia are also unlikely to they'll take in your consideration for evacuation methods, but in reality, they're probably just going to make their own decision with what's appropriate. So with this, we need to hand over the most up-to-date relevant information and triaging our patients accordingly for that. And that can also have a difference of what hospital they go to. But with aeromedical evacuation, so helicopter landing sites, the pilot will make their own decision on where to land. All right. They will not rely on your directions and your suggestions. However, your suggestions, like any other things, are worthwhile, especially if you have knowledge. All right. So you consider how to bring the patient to the helicopter. We're making a suggestion, but they're gonna have all this information that they're considering because they're the professionals. They do it all the time. So things we need to be mindful about is the day. So is it nighttime? Is it is it light? The wind direction, the openings it has. I've been in a situation where unfortunately we weren't able to get off the mountain until it was light because we were waiting for the helicopter to winch a patient I was treating off the hill who could not walk, and we couldn't stretch him down. So with that, the helicopter wasn't able to do that during the darkness. So we were waiting about 4 hours for that to sort of for light to happen and to get the patient off. With this, you can see how to sort of set up a helicopter landing site. But it really just depends on where you are, the capability that's available, and the crew that is coming.